OEBB year today. Before we look at the agenda, if I could call roll real quick, please. So, JJ, are you there?
I'm here.
Okay. Jeff is not here today. He's on vacation. Michelle. Okay. We'll see if Michelle shows up a little bit later. Enrique. Okay. How about, and I know Bill's here. Bonnie. Bonnie. Okay. Susan Miller's here. Susan Ricky Smith is here. Bob's here. And is Tom here? I think he might not be here for this session. Well,
do we have a quorum, Rob?
Do we have a quorum?
We're gonna need one more for a quorum. We got 6.
All right.
So we can cut the minutes off.
So we'll cut the minutes, and anything that requires action we'll loop back through just in case we have another person show up. This is
here's Enrique. Hello.
Okay, so Enrique's here, so we do have a quorum now, right, Ali?
Good to go.
Yeah.
All right.
Sorry, guys.
There we go. Well, our first course of action as a quorum group will be to look at the board meeting minutes, which is included in the packet that Rose carefully put together for us.
Move to approve.
Wow. Okay. I think, was that Bob move to approve? Is that correct?
Yes.
Okay.
Bill seconds.
Okay, Bill seconds. Okay, so all in favor of adopting the board meeting minutes as written, signify by saying aye.
Aye.
Aye. Aye.
Are there any nays? All right, the board meeting minutes have been adopted. All right, so first on the agenda is we're going to be presented with a COVID-19 vaccination landscape update. And I think Kaiser is the first to go. So I do believe.
Perfect.
Or
Yes, thank you.
I'm just going to make sure because I saw Moda on there. So Rose, should we do Moda first then?
It's up to you. I don't know why I got him changed around. Did we change him for you, Sapari, for scheduling?
You did, thank you. Yeah, I think we were on first, if that's okay.
I didn't change the, sorry. Okay, wait, there you are. Right?
Perfect,
Yep,
thank
that's
you.
it.
Okay.
Okay, all right, I'll kick it off. Thank you, Robert. Our presenters today will be Dr. Giswold, who is our COO of Permanente Medicine. And also we have with us Wendy Watson, our COO of our Kaiser Foundation Health Plan and Hospitals. And I also like to refer to them as the dynamic duo, as they have been key in leading our organization through the ups and downs of the pandemic. Our presentation today will mainly be focused on what's happening in care delivery, and we invite you to ask questions throughout this discussion. And so with that, I want to give most of the time to them, so I'll turn it over to Wendy to kick us off.
Great, thanks, Sapari, and thanks for having us. Dr. Giswold and I actually love talking about COVID because this has been a big part of our lives for the last few years. We were there for that first phone call when the first patient was admitted at Westside. We were there physically at our Airport Way site when the first vaccines arrived, and have been there every step of the way with our team. So we are forever changed as a result of COVID. So today we're going to give you just a quick update on where we're at with some of our COVID trends, testing, vaccination, and then some of the impacts of COVID, and then how we're dealing with those impacts with respect to access to care. So if you go ahead and go to the next slide, just kind of taking aerial view of all of the surges that we've been through, just gives you perspective. And this, the big surge, we had Omicron in the January, February timeframe, we had over 200 Kaiser Permanente members hospitalized with COVID during that timeframe. In the late June, July timeframe, we had 80 to 100. You know, the BA.5 dominant is now the dominant variant. Definitely has increased resistance, but thankfully reduced serious illness compared to some of the previous surges and variants. One thing that is a little bit deceiving from this chart is it makes it look like hospitalizations are down significantly, but actually this is just the COVID admissions. Hospitalizations themselves remain very high, and I'm sure you've been hearing that across the whole community. All systems really remain full from a hospital perspective. One other thing I wanted to bring up with regard to, you know, having had these multiple surges and going through this COVID experience is the population of patients who have what we call long COVID, which can be anywhere, you know, 20 to 30% of patients who have COVID who end up having symptoms a lot longer than the typical experience, 1 month or more. We have stood up a long COVID clinic within Kaiser Permanente where we've been able to take and really learn from the experience of patients who've had COVID, these extended symptoms with COVID, and pull together all of the departments that are able to come together to provide coordinated care for this population of patients. So departments like pulmonology, cardiology, mental health, endocrinology, sleep, all of the different specialties, in addition to primary care, to really help these patients with the long-standing impacts of COVID. So let's go ahead and go to the next slide, and we'll look at vaccinations specifically. I'm not going to go through all of this. The main point here is vaccinations for COVID have become very complex, lots of different options, but vaccines are widely available. We're able to get everyone vaccinated. This is really just the eye chart in terms of what the requirements are for the different age groups and the different options that we have available. So let's go ahead and go to the next slide. So looking at vaccination rates, so if you look at vaccination rates for OEBB specifically, they actually look really good. They're higher than our overall KP Northwest population. So we've got 83% of OEBB members who have at least initiated the vaccine series, and then 81% that are complete. And then 67% of OEBB members have been boosted. Down on the bottom, you'll see the race and ethnicity vaccination rates. This is for KP Northwest as a whole. We've really been focusing in on this to ensure that we're providing equitable access to vaccinations. And some of the ways that we've used this data is taking some targeted actions for specific populations. So one thing that we've done, and this is KP nationwide, we've done a COVID-19 education campaign targeted at the Black, Latino, Native Hawaiian, Pacific Islander populations, using social media influencers, public service ads, bilingual, and then also really leveraging community-based organizations that support these populations, and making sure that we're getting the message of prevention and the importance of vaccination to those populations. We've also done targeted vaccine events. We've done events targeted at Pacific Islander, the Black and African American population, Hispanic and Latino population at some of our medical offices. And in addition to providing these targeted vaccine events, we've also used that opportunity to close care gaps. So looking at, for every patient who comes to the vaccine event, we look at, are they due for blood pressure check, mammogram screening, cervical cancer screening, and then we're able to get them plugged in to address those health care gaps as well. And then finally, we've been partnering with Medical Teams International to do vaccine events out in communities, and they've been able to deliver over 12,000 vaccines and gone to 70 communities in the Portland area. Let's go ahead and go to the next slide. So testing, one slide back, please. Testing, you know, we've had periods of very high testing demand. We're now at a state where we've really leveled off. Testing is widely available. All KP members can make an appointment or walk in. We have it at 9 locations across the region. Turnaround times are within 24 hours, so really easy access to PCR testing. We also have antigen tests available in all of our pharmacies. So main message here is, you know, testing we're able to do quickly and easily. and results are available quickly. Just for point of reference, just for a number, we've done over 100,000 tests for OEBB members since we began COVID testing. And then next slide. So moving from surges, testing, and vaccination to really what's the impact we're starting to see with COVID. If you could go ahead and advance to the next slide, please. We're in what I refer to as kind of the shock wave portion of COVID. So there are consequences now of these, the period of time that we've been dealing with COVID and these repeated surges. The pandemic has really left healthcare in a fragile state, and there are a number of things that we're actively working through. One of the things, I don't know if you all are aware, but Oregon has the lowest hospital bed capacity in the United States. And so you take a community that's low on hospital beds and then you add a pandemic on top of it. And that's what we're starting to see with the hospital beds. And it's why all of our hospitals remain full. Demand also is high. So we saw, really dip down during some of the earlier phases of COVID. And now we're really starting to see that deferred care coming back and a lot of people needing care that was deferred during the pandemic. We're seeing a lot of impacts on healthcare workforce. So a lot of retirements, resignations, and then the whole job market has simply changed. All healthcare systems are competing for a much smaller pool of talent. And that's really had an impact on us, both on being able to fill positions, but also we rely much more heavily now than we want to on travelers and overtime in order to ensure that we have staffing to deliver the patient care, which has also put financial pressure or added financial pressure. We also, COVID has impacted our own workforce too, in terms of ill call, which has further exacerbated the staffing challenges. Patient complexity too has also increased. So we're seeing that across the board in our hospitals, in our outpatient clinics, with patients who, perhaps waited and didn't come in during the pandemic. Now we're seeing conditions a lot more serious at this point. Burnout is a big issue as well, and it's really feeding into some of the retirements and the resignations as well. And then just the added cost, adding to financial pressure, COVID testing. We've spent about $38 million in 2021 on COVID testing, about $19 million on COVID vaccinations, and those are all unbudgeted costs that continue into 2022 and will continue into 23. So that's just high level in terms of some of the impacts we're seeing from COVID. Mary's going to go into more detail now and how we're addressing that with respect to access to care. So Mary, I'll turn it over to you.
Thanks, Wendy. So I just want to continue on in what Wendy was talking about how we've had this impact of deferred care. So we're seeing increased demands and, and having to do things very differently. So we are, one advantage we have as an integrated system is we can really look at how do we structure our teams and ourselves to meet the needs of this higher demand where we have a strained workforce. And it has been an innovation catalyst for us in many ways where, for example, during the pandemic, we began our what we call KP at Home, which is our hospital at home program, where we've hospitalized, almost 1,800 people in their homes. And we've also had a history of, doing what we call surgical home recovery, where we try and get patients home as quickly as we can, that within, in a safe way after their surgery, so that we're really using those beds for patients who need them the most. Yeah, please back up one slide. Can you back up a slide, please? We also, to help meet the demand, are getting more innovative around virtual care. So we are offering what we call Get Care Now, which is a virtual urgent care on demand. We also have e-visits, which is an algorithmic based technology platform that allows patients to input their symptoms and their concerns, and it helps, and with the oversight of physicians, brings out a care plan at the end. And really what we want to recognize is that still choice matters, and we want our patients to be able to interface with us in ways that A, is appropriate for the level of care they need, but B, also gives them choice. We are definitely seeing patients more and more want to come in and see their doctor face to face and have that personal connection with their clinician. And we're very focused on that right now. I want to say a little bit about surgical backlog. As many of you know, during various times during the pandemic, we did have to scale back surgical procedures in order to create capacity for COVID patients with COVID-19. And right now, we are prioritizing our urgent type cases. So cancer care, patients with pain, and those patients get in a very timely manner. We do still, though, have waits for patients who are having things that are more elective in nature, meaning they can, they can it can wait, a little bit. So, for example, for a total joint replacement, on average, our patients are waiting about 5 months. For bariatric surgery, about 8 months. Hernia surgery, 3 to 4 months. So, we are still experiencing some waits for those types of cases, but for the patients who, need cancer care or are having extreme pain, we are getting those patients in very promptly. So I want to switch gears and talk a little bit about mental health. As many of you probably are aware, the demand for mental health services through the pandemic has gone up considerably. We're seeing a significant increase in suicide attempts, substance abuse needs, a 4-fold increase in depression, 3-fold increase in anxiety. PEB received 25% more BHC services in 2022 versus 2021. And so a significant increase. In order to meet the demand, we are really trying to hire up. We're adding many new therapists. We actually are onboarding about 14 this month. We are removing some of the barriers to appointment and prior authorization so that patients are get through the process in a more expedited way. We also have done some innovative programs where we are putting what we call BHCs or behavioral health consultants into our primary care clinics so that for more lower acuity mental health needs, they can be met right in the primary care clinic. And we have been, as we've expanded this program across our region, we have seen a significant reduction in our clinics that have BHCs in the need for referral to more specialty mental health services. We also are just expanding our pipeline of to help bring more therapists and mental health workers into the field. Next slide, please. In addition to hiring and growing our mental health services, we have launched what's called Ginger, which is a self-referral technology platform where people can do one-on-one coaching for many, common challenges we all experience, from either stress or just some low mood to issues with work and relationships. And using this platform, people can text their coach 24/7. The service is available for up to 90 days, and people can just get some personalized, interactive help for kind of some of these lower acuity mental health issues. In addition, we also have availability of a Calm app and some other technology platforms to help meet the demands. Okay, next slide, please. So as I alluded to earlier, we are seeing increased demand for just primary care services, specifically face-to-face care for primary care. I think we all saw, what is possible with virtual care during the pandemic, and really what more our patients and frankly our clinicians want in order to provide really the best care for our patients. So we've been very focused on redesigning our primary care experience so that we are attracting and retaining really strong primary care clinicians. We are very focused on really restoring this relationship between the primary care clinician, the medical assistant, and the patient, so that there is we're really supporting that relationship between the primary care clinician and their doctor. We know that when our patients interact more with their primary care provider, they generally have higher satisfaction. We do better with identifying social health needs, closing quality care gaps. Okay, next slide, please. Urgent care has seen a considerable increase in demand over the last, sorry, my lights went out here in my office, so you're gonna just see me in the dark a little bit. In urgent care, we've had a real increase in demand as well. We have seen probably over a 10% increase in demand on our urgent care in 22 from prior to the pandemic. And, you know, knowing that we just can't all of a sudden hire more staff, we have really looked at how we bring patients into urgent care, how our patients experience urgent care, and have redesigning how the patients come into urgent care and the whole visit flows. And we're really focused on how quickly a patient goes from checking in to seeing a physician and just the total length of the visit. And in just redesigning how we bring patients back into the back office, how we do triage out front, we're seeing a 25% reduction in wait times, and overall visit time is reducing. Nobody wants to go to urgent care and wait 3 hours or be there for 5 hours. It's urgent care for a reason. We want people to come in, get their needs met, and get them where they need to go, whether it's escalated to an emergency department or hopefully in most cases it's back home. As I said earlier, we're also offering Get Care Now, which is 24/7 online urgent care. Okay, next slide, please. Monkeypox has gotten a lot of press lately and is certainly a new disease on the horizon that came at us in July. And we, given our experiences with COVID during the pandemic, pulled together a team to work this issue and making sure that we were working closely in coordination with the state and public health, as well as our national partners at Kaiser Permanente, so that we are providing, you know, state-of-the-art, up-to-date care on monkeypox. Fortunately, monkeypox does not pose the same threat to our members and to the staff as COVID-19 does. But, you know, some of our learnings from COVID really helped us get ourselves organized quickly. When this slide was created, there were a little over 200 cases in Oregon and Washington. We have seen several cases in Kaiser Permanente. We have gotten our vaccination program up and running, and we are offering vaccinations across our region in every service area. And right now, the vaccines are given on a eligibility in line with what the CDC recommends, and it's a self-referral type thing. So I think really at this point, Wendy and I are happy to take any questions that you all may have.
So any questions for Mary or Wendy? Thanks, that was really informative, and you were right on time too. Appreciate that.
Thank you.
Thank you.
All right. Sorry. So now we're moving on to MODA. Sorry for the delay. I had to pull up my agenda again. Perfect. Thanks, Rose.
That's not that. Go to the beginning. That's halfway through.
Almost perfect, Rose.
Almost perfect. There we go. There we go. Thank you, Rose. So good afternoon. I'm Yale Popowich, the Chief Medical Officer here at MODA, and I will be talking today about the Oregon provider landscape, a little bit about inflation, long COVID, and then I'll turn things over to my colleague Bill Dwyer, who will discuss the impact of COVID on utilization. So next slide, please. So here's my brief agenda of the things I'll be talking about. I realize that some of this information will overlap with that presented already by our Kaiser colleagues, but hopefully it will still be of use and illustrative from coming at things maybe from a little bit of a different perspective. So next slide, please. So when it comes to the Oregon provider landscape, it's been no surprise to anyone the impact COVID has had, particularly on staffing challenges throughout the state. And this has had a cascade effect touching on many different areas, as well as crossing over into the dental field as well. So offices are struggling to hire frontline staff. Many caregivers are, whether it's physicians, nurses, whatever, medical assistants, they're just stressed to the point where this is not necessarily the career they want to pursue, so they're leaving. And then there's deferred care during the pandemic, which has led to an exacerbation of conditions and people not seeking the care they normally would have in as quick a fashion as they normally would have. So this is creating demand for healthcare that's outpacing supply. The provider financial struggles are real, in particularly hospitals, due to inflation and in particular, again, these labor costs, which then puts further pressure on hiring and hours that they can operate, and this domino cascade effect just continues. There have been, when it's come to contracting and our medical provider relations teams here at MODA, there have been much higher rate increase requests than we normally have seen, just because providers are doing their best to stay afloat. And there's been general provider unwillingness to engage in anything that is not fully aligned with direct patient care, since areas like value-based care, data analytics, back office staff can take a little bit of a back burner when it comes to just taking care of their patients. There have also been structural problems in the healthcare system that are going to take time to work out as each provider takes customized approaches to dealing with their specific issues while still trying to treat their patients. So some of the solutions that are on our radar: providing incentive contracts, PMPM support for primary care, reasonable rate increases that help cover some of these expenses that they're now dealing with, streamlining the provider contracting and credentialing process to onboard new providers quickly and re-credential those who are up for re-credentialing quickly as well. And then, of course, telehealth options, particularly in the behavioral health space. Next slide. So I'll just touch briefly on inflation. We all know that inflation is a very prevalent topic right now, and there's a lot of uncertainty about where that's going to, where and how that's going to affect things. Seems to be exacerbated depending on the payer mix of hospitals and providers. Older patients are driving higher cost profiles, but more stable changes. They're already high, so their percent change is smaller. Healthy patients who are only using PCP services, who are a lot of people, but a relatively small part of total cost of care, are going to have slower cost growth. Any use of advanced technology, from drugs to implants, including those providers who use or supply them, will have a higher cost trend. And smaller, often rural hospitals are more likely going to bill on a percent of costs. It's all projected to have much larger charge master increases than hospitals with bundled services currently have, or reimbursements that are tied to a percent of Medicare. Next slide. So inflation from the supply side is going to increase costs for all kinds of care: staff, supplies, drugs, utilities, insurance. And I'll leave it at that. So we can stay right there on the implications of long COVID. And so long COVID is talked about a lot, but it's really not still completely understood, and truly is a time bomb whose implications we've yet to fully see. I included a couple quotes here that I thought were pretty relevant to the discussion. Estimates of the proportion of people who have had COVID-19 that go on to experience post-COVID conditions can vary. Some estimates say that over 13% at 1 month or longer after infection will start to experience this, 2.5% at 3 months or longer based on self-reporting, and more than 30% at 6 months among patients who were hospitalized. Next slide. The implications of long COVID may be a disability under the Americans with Disability Act, and as such, this is going to affect employers who will have a legal obligation to provide accommodations for these patients, and this is still an ongoing urgent topic of discussion within the government. Common post-COVID symptoms, and this list is seemingly endless, but some of the bigger ones are fatigue that interferes with daily life, symptoms that get worse after physical or mental effort, fevers, respiratory issues, including difficulty breathing or shortness of breath and cough. Next slide. Body systems input with post-COVID systems, heart and lungs, neurological symptoms, brain fog, digestive symptoms, musculoskeletal system issues, joint pain and muscle pain, for example, mental health issues, which I'm going to touch on in a moment, such as depression and anxiety, and unexplained symptoms that are just simply hard to diagnose or manage. And I think providers are going to be seeing a lot more of this over the next few months when they have patients coming in with these types of symptoms. So next slide, the implications of long COVID, as we know, in particular in people who have had chronic disease prior to COVID. People with chronic disease are a disproportionate part of overall healthcare costs. Their conditions are going to become more severe and will have an outsized impact on overall health care costs. The 550 rule may become the 570 rule. And even though this slide did not make it in here, I do want to just say a little bit about pediatric care. There's less information about the extent of missed routine pediatric care. But in March of 2020, pediatric outpatient care visits declined by over 70% for children less than 18. And pediatric visits remained below pre-pandemic levels through October of 2020. Data also showed that from March to May of 2020, 500,000 fewer US children received blood lead level screening, 10,000 of whom may have had elevated levels requiring intervention. So, as well as highlighting concerning gaps in vaccination coverage, these data are suggestive of significant and potentially harmful disruptions to routine pediatric preventive care as a result of the pandemic. The belief is that it will catch up as quickly as the system can handle it and as people feel safe and comfortable, as we are already starting to see in data of members coming back to see their pediatricians, particularly this summer, pre-going back to school. However, for missed care, the impact could be longer lasting and even permanent. Next slide. We're all aware of the impact that COVID had, the public health emergency had on mental health, and this is a really important one. These are issues that were particularly sharp in the under 30 populations, and really raised a lot of awareness about an issue that was already prevalent and important prior to the pandemic, but really with the pandemic, the Band-Aid was sort of, in lack of a better term, really ripped off in raising awareness of what the implications of COVID had on behavioral health. So next slide, please. So compared to pre-pandemic levels, and this is data that's right in line with what our Kaiser colleagues reported. But there have been three times more individuals reporting symptoms of anxiety and depressive disorders, close to 3 times more individuals reporting suicidal ideations, a 30% increase in drug overdose deaths, 50% increase in the number of individuals with a behavioral health need. And this is also super concerning. In addition, the increase in behavioral health needs is disproportionately impacting racial and ethnic minority groups by a factor of 1.2 to 2 times. So next slide. So in summary, the Oregon provider landscape adaptation recovery is going to continue to be very closely watched. Inflation remains a deep concern. Long COVID could have devastating clinical consequences, so that is being monitored super closely as well. The costs of long COVID, what will they be? Will there be a true rebound in deferred care? And if so, how much? There will be consequences of untreated chronic disease and undiagnosed acute diseases, but again, by how much? There will be increased mental health costs. The increased prevalence of these issues will conflate with other care costs because depression, as we know, can exacerbate other chronic disease conditions. And lastly, people with long-term unresolved post-COVID issues, either from the virus or from decline in a condition, will be costly, and the cost of which will remain to be seen. So with that, I will turn things over to my colleague, Bill Dwyer, who will talk about the COVID impact on utilization.
Bill, you're muted.
Thank you. Okay, well, I'm going to show you some data. It's mostly on OEBB members. Some PEB member data is in there as noted. There's 2 sections to this presentation. I'm going to go through them pretty quick and try to get through them in the next 8 minutes. So I'm going to skip a lot of things. And just the time period on here is noted so that it corresponds closely to pre-pandemic and the first year of the pandemic and the second year. So I'll just go to the next slide. Okay. And fortunately, this is the only slide I have that looks like this with a ton of numbers on it. And I'm not going to go through all of this. I'm just going to point out, if you look at the 3 years, 2019, 2020, and 2021, you see that utilization is high in 2019 and then drops way down in 2020 and then comes back in 2021. And so it'd be natural to say, well, in line with what some of the other folks have said, so there was a reduction in utilization in 2020, and now there's a lot of pent-up demand, and it's come back in 2021. I'm going to show you later in the presentation that that actually is not what's happening here. So let's go to the next slide, and at your leisure, if you'd like to, if anyone has any questions about some of these specific categories, I'm happy to answer those. Here are some observations on that previous slide, some examples. So if you look at the second bullet point there, inpatient is down, with elective procedures showing the biggest decline. So people are not, the number of services that they're getting on an elective basis is still lower than it was pre-pandemic. ED utilization is still lower. Outpatient surgeries, those are generally elective, they're lower since 2019. A lot of these other categories are higher in 2021 specifically because of COVID treatments, vaccinations, and testing. So we've got an increase in lab tests, which actually is driving an increase in lab unit costs because those are expensive, those COVID tests, compared to other lab tests. And other primary care, there's some vaccinations showing up in there, in testing. Turns out that a lot of the vaccinations and testing is not entirely happening in the primary care setting, it's happening all over the place, which is great. The vaccines are also driving up brand name utilization, but actually lowering the brand name drug cost because they're relatively cheap compared to other brand name drugs. So these and other utilizations can come out of the chart I just showed you, but I want to keep going to some of the main conclusions. So let's go to the next slide. I'm going to go to the next slide. There we go. Okay. There's $800,000 worth of additional cost in the form of COVID vaccinations for the OEBB population. Totally worth it. So you can see, unfortunately, though, that the other vaccinations have declined since 2021. So I pulled out some of the larger vaccination categories, and you see that they're, for the most part, lower. If you look at the bottom left, you can see where the numbers of vaccines, they peaked certainly when the vaccines first became available, but the number of members that continue to get them has fallen since then, and it's pretty low in comparison. So, in other words, yes, everybody got the first few shots, but then, the race to getting all the additional boosters and everything, it's just not happening the way that the initial vaccinations happened. Let's go to the next slide. One effect of COVID has potentially is that risk scores have been affected. And this is at the basis of a lot of the analysis that we do. We've got OEB and PEB showing here, and you look at the leftmost 3 columns there under retrospective risk. That's a risk score that takes into account the diagnosis and prescription history. And you can see that those are lower compared to 2019, where the next 3 columns over, the demographic risk, that's just based on somebody's age and sex. And those are pretty much the same. And so you could have a number of hypotheses from that. Maybe people are getting healthier during the pandemic. I give that one a thumbs down. I don't think so. Office visit utilization is going down, so perhaps there are fewer opportunities to document the conditions that people have. Also possible, given that providers are burdened, they're not documenting all the conditions that people have. In any case, we're going to have to be very careful about the use of risk scores in the next couple of years because of this. Let's go to the next slide. This next section has data on both OEB and PEB members. I assure you, this has nothing at all to do with the fact that I didn't want to create 2 different presentations for OEB and PEB meetings. Actually, I just wanted to have the largest data set possible. And so I'm going to show you some data on the combined population. Let's go to the next slide. So right off the bat, so about 12,000 members got documented COVID-19. Probably a lot more than that didn't get it documented, but you can see there on the left, that's the number of COVID members by calendar year. And then on the right, the number by month, where you can see the different peaks from the different variants of COVID. I want to go to the next slide. And this one really shows what is happening in terms of overall utilization for people who do get COVID. So what this chart shows is the total allowed per member per month spending on members who had COVID-19 based on the number of months pre and post infection. So where you have this big peak there, that's the 0 month. That's the first month in the claim data that member showed up with a COVID diagnosis. There's a number of really interesting things from this. So obviously, the biggest thing that you take away from this is costs spike dramatically in the month that somebody gets it, mostly because of hospitalizations. The other thing you notice is costs remain elevated for several months after they get COVID. However, you also notice that by about month 7 to 12, costs are just about back to where they were before for these members who do get COVID. And if you go to the next slide, there's a table that shows these in actual number terms. And you can see that the trends here, this data is highly suggestive that after about 7 to 12 months, that the trend will be back in a normal range for somebody who does get COVID. There's a bunch of bullet points here, running out of time. I'm going to keep going. You can read those and then submit your questions. So let's go to the next slide, which I'm actually going to skip. Let's keep going here. Okay, let's skip that one. Here you go. This one shows the overall cost by member cohort. The green line is the COVID member. Okay, the green line was the COVID members. And you can see that the COVID members are really the ones driving the cost. Okay, I'm not sure we're going to get back to that. Okay, well, we'll stay on this slide. So this is where we are. So this, okay, the green line there shows the COVID members, and you can see that for the members who do not have COVID, their trend is not a rapidly increasing cost trend like we saw. So now we're circling all the way back to my first slide where I was making the comment that, oh, it's the utilization has come back now. There's pent-up demand and all that. So what the data that we've seen so far does not support those types of hypotheses. I'm going to skip and now and just go to my last slide. So skip until you see a slide with some bullet points on it. Okay. And so here are some things that you might. So initial theory, as I mentioned, revised theory is that utilization continues to be depressed. Can everyone see this still? There we go. Utilization continues to be depressed below 2019 for people who have not had severe COVID. And the costs for infected members are high, but they're decreasing in severity. And so when somebody gets COVID, a return to sort of normal-ish cost and utilization may occur within 7 to 12 months. And so, open questions. When is the utilization for the non-infected going to recover beyond 2019? Hard to say. Will it ever recover? It might not. And then will continued waves of COVID-19 infection continue to drive trends higher? We'll see about that. And I think that's all I have to share. If there's any questions, I'd be happy to answer them.
Bill, I do have one question attached to your open questions. It's the why question. Why is utilization down among the non-COVID, the non-infected?
Yeah, that's a great question. So, take emergency room, for example, where the emergency department claims are lower. And it's possible that people have just gotten in the habit of not using that because of fear or because of other reasons. And once so that just like we're having this Zoom meeting now, it might just be the new normal that people have adjusted to a different pattern of utilizing healthcare services.
Okay, thanks. Enrique, you have a question, comment?
Yes. Thank you, Mr. Chair, board members, good afternoon. I do have two questions. That'll be for our friends from Kaiser and Moda. Maybe they can tag team and help me understand. I understand the federal government provided a substantial amount of states' financial support when it comes to the COVID vaccines. So I guess my question is, how did Kaiser and Moda utilize such resources? Because what I'm hearing as a consumer is that it's costing the system money, but yet the state and the healthcare providers receive an X amount. And how is that calculated into your formulas? That's my first question.
Hi, Enrique. This is Sapari. Maybe I can respond on behalf of Kaiser Permanente. So yes, the cost of the vaccines were definitely free of charge. However, the administration is what we were reflecting. So the administration, so the individual, providing the actual injection to the member, there is a cost involved in that. Is that what you're asking?
Yeah. Okay, that's the answer to my question. So when the federal government provided such funding, it was just for the vaccine, not for use in the staff time.
Correct. Yes, correct.
Okay. I guess that's the same thing for Moda, right?
Mm-hmm.
All right. So I guess at the bigger picture, a global picture, I really appreciate our friends from Kaiser saying that we have a chronic systems issue on the rural statewide hospital beds. I am disappointed to hear that Oregon is behind this capacity that we have if we call ourselves progressives as a state, which I think it's fake sometimes, but this is an aside. I guess as a board, what action can we do, or what do you need from us as a board to collaborate with you and increase access to healthcare, which is my members and the members of others here and your clients need? What do you need? A state action? Do you need an action from OEBB? Or how can we increase that capacity? Besides, I guess the money comes down to money, right? But what are the steps that you guys see as professionals that we need to do?
Enrique, this is Ollie. I just want to jump in and let the board know that next month the entire board meeting will be devoted to discussing access issues, looking at data, what things can be done, what things are being done, and just to kind of prime for that discussion. It's a great point, obviously, and one that's extremely important right now.
Awesome. Oh, thank you, Eric, for
yeah.
I did read the board reports. I was trying to kind of get ahead myself here from them. So I appreciate you keeping on my toes. Thank you.
Any other, Subriki Smith, you're up.
Thank you, Robert. Robert, I think your question is a salient one relative to just taking one slice, looking at emergency care. And Ali, I guess my question then comes to you. Will questions like that relative to the upcoming October meeting, will we dig into that data? I have, along with Robert and Enrique here, I do reading this and then reading the article in the Oregonian on September 3rd relative to the hospital system as a whole. It raises concerns around, are people just giving up on the system? Are they finding other ways to access care that may be suboptimal? All of that. And so I guess my question to you is, will we have an opportunity to look at data and have that conversation in October?
Yeah, absolutely. Actually, we are sending out criteria for the presentations in October, and I'd be happy to run them by some board members just to make sure that we're capturing everything that you'd like to discuss.
Thank you so much.
Anyone else? Really good question so far. Okay. All right, well, thank you very much, Bill, and yeah, I appreciate the discussion on that. Okay. All right, we do have a revised agenda for flexibility. We are going to move on to a discussion on repealing a permanent rule that we put in place. I think it was last year, and it was COVID related. So April, are you ready?
I am just trying to get my computer to work with me. Can you see me and hear me?
Yes.
Yes. Okay, great. Thank you. Okay, so today I'm here to talk about, I'm April Kelly, the rule coordinator for PEB and OEB, among other duties as assigned is what I call it. But I'm here to talk about, I see you guys chuckling, OEB's COVID OAR. We refer to it as our COVID rule, which is actually Division 111-015-0005. And just a little bit of history on this. In April of 2020, we kind of jumped on it as well as with PEB, and we adopted a temporary rule that addressed some key points in terms of eligibility. And we got those approved, and they were temporary for 6 months. Kind of going into the summer months, we just realized that that we needed to extend it longer, and we were unable to extend temporary rules, as there is a statutory limitation to 180 days. So we actually brought this back to the board in the fall of 2020, and with a few kind of tweaks to it, but we did get this approved to be a permanent rule. And when you perm what we call a perm rule with Secretary of State, when you need to now repeal a rule, we went through the rulemaking process to repeal it. And we did go to board leadership in July. Normally it would go to the full board. I would be presenting to you, asking, to go through the process, but in July, you all didn't have a board meeting. So we did go to board leadership, and they gave us the approval to start the rulemaking process to repeal our OEB COVID rule. And we did go through the rulemaking process, which includes a notice, public comment period, and a rule hearing. And we didn't receive any public comment. And then nobody attended my rule hearing, so I sat there by myself. But at any rate, we did do all the necessities for the public rulemaking, and I'm now here asking for your approval to repeal the rule as permanent.
Do I have any comments or questions regarding the repeal of this particular rule? So one of the reasons we extended it, especially through the summer, is that it did provide furlough, benefit protections for furloughed employees. We got extended through the summer of this year so that the entire cycle from last year, the educational cycle and hiring and terminations were completed. And so it's very likely no longer necessary, and that's the reason it's being repealed with the upcoming school year.
This bill, I'll make a motion to repeal permanent rule OAR 111-015-0005.
This is Stuart D. Smith.
And I'm assuming he got the number right. So all in favor of repealing the stated number of the OAR signify by saying aye.
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 Do I have any nays?
Aye. Aye.
Nay.
Okay, I'm sorry?
One nay. This is Michelle.
One nay. Okay. I do believe that the ayes have it, so the motion to repeal has been approved.
Great, thank you so much.
Okay, we are way ahead of time because that took a little bit less time. So let's see. We are at the part now, local government's participation update, NOEB's growth targets. Todd, are you ready to go?
I am, thanks. Can everyone hear me all right?
Yeah, we're actually not ahead. I was misreading it, so we're right on time. Yes, Todd.
Great, great, thanks. Okay, as was mentioned, we're going to talk for a few minutes about participation at OEBB by local governments and special agencies. So again, 4 quick sections. We're going to do a brief background, talk about what we experienced and what we learned in year 1, and then talk about some of our ideas and suggestions for how we go forward in year 2 and beyond. Okay, we can probably skip 2 slides because I think the next, yep, there we go. Okay, background. Really just talking about the current process by which local governments and special districts apply to join OEBB or PED. So currently they issue us a notice of interest, make those plan decisions, then we go to work on our side doing the plan rating, and then they go live. You can see that out of 255 total entities in OEBB, currently only 9 are local government or special districts. So we're identifying this is a real area for growth and want to focus on ways to effectively get those groups into OEBB. Go to the next slide. So again, let's talk about what our experience has been to date. As you can see at the top, we actually had 4 inquiries, possible interest in joining the group. Only one of those 4 joined. If the group wants, we can get more into to reasons and all of that. But let's talk in general about what the findings were as far as what those possible candidates saw as pros and cons of joining OEBB. So of course, on the pro side, rate stability that they just can't get as a group their size, the sort of stability that comes with a group like OEBB. They like the centralization of administration activities. Many expressed positive feedback about the number of choices available, although as you'll see in a minute, there was also some feedback that some of the choices weren't as rich as what they might have been offering currently. Then last on the pro side, just access to those really good rates for other ancillary products that come with being part of the group. On the con side, the feedback indicated, for folks that didn't end up joining, they felt that the savings was limited compared to the amount of disruption that would happen by moving into the group. plan richness, what I just mentioned a minute ago, especially for some groups that had, much richer plans. And while they wanted rate stability and wanted to be part of a larger group, they weren't willing to give that up. And again, there's currently no coverage for police and fire through PEP.
So Todd, can I ask a question right here? So
You absolutely can. Yeah.
on the on the cons, the savings aren't great, and according to their feedback, the savings is minimal, and they're not providing and that we're not providing as rich of a benefits. So how is that? May be the feeling, but how is that actually possible?
So I think I think that's two different groups that were expressing those two different pieces. So I'm guessing that the limited savings folks weren't the folks that were coming from very, very rich plans. I think those were probably folks that had a similar benefit option coming into PEB, but felt that based on the savings they were going to get, just had to deal with too much disruption in return, if that makes sense.
Yes, Bill, follow up.
Yeah, I had a quick question. Is CIS the primary competitor here in Oregon for this?
Yeah,
there's a bunch of local governments that have CIS, but they only cover, I think, about 20,000 lives or 25,000 lives.
So who is the primary competitor here?
Well, I think going back to the comment about the cons, I think, in the past few years, the local governments will have a broker that they're working with or a broker agency, and they run their numbers, and we've never really had resources to kind of counter that and offer a more objective assessment. That we now have Georgianne Helmuth that the board's met, and to really act as more of a broker, obviously not with commissions, but be able to provide that engagement that's necessary to kind of quote close the deal and give them the information that they need. So I think sometimes, insurance is complicated, as we all know, and there's a lot to be said depending on what kind of numbers are being compared and plan values as well.
Okay, Enrique, your hand's up.
Yes, I guess this is my third board meeting, but who covers the police and the fire if PEP doesn't cover them? Is that the same response? Did you just answer, Ali?
No, it's actually they have associations. I'm not exactly sure. This one's a complicated one. We've actually submitted a legislative concept to get that legislation changed. We really don't know how that ended up in our original legislation. But for whatever reason, the legislative concept did not go through. I think if Glenn's on, I think we submitted it 2 or 3 legislative sessions, and there's obviously someone out there that does not want that to happen. So so I wish I had more information, but
I can answer that, Ali. Most police associations, if they're not covered by CIS, which is a city county insurance, they are covered by just the various different insurance companies. So a city or a county will just have a plan through Pacific Source or a plan through Blue Cross Blue Shield, and they'll have the pool of their specific police force is either a unique pool in itself, or the city or county as a whole will be one pool.
Okay.
Yeah, Ali, this is Glenn. Yeah, we've submitted that legislative concept, I believe, several times, and it was originally really an association, and I believe it was the firefighters in the beginning who put that into the original legislation as a condition on supporting it.
Thank you.
Okay.
I guess my question. Sorry.
Go ahead,
Mr. Chair. I guess my question was because I see it as a con But it goes back to the previous data that it was shown that the cost of healthcare and how we need to be more competitive to provide services to, I mean, the more people we have in the plans, the theoretically speaking, the cost will be lower. But what I'm hearing is the cost continues to go up. So I think it will be in our best interest to include the police and the firefighters into our policies. I don't see why they have special privileges if they're still being covered by the same hospitals across the state.
And they are covered under OEB, just not under PEP.
So, right, they're currently covered, but the caveat there is that most of the OEB plans are not as rich as what those folks have under their current arrangements. So that's sort of a barrier to them joining.
Okay, thank you for clarifying.
Yeah.
All right, Todd, I don't see
Should we go
anybody
on?
else, so continue on.
Thanks. This last column is really not just rule changes, but also kind of a response and the work that's being done to address some of these cons. So I know that currently, I believe Georgianne and others are working on updating the agreements for local governments. That's one of them. There's also an opt-out. There's also a desire to add an opt-out provision so that folks have the option to leave once they've joined, like a one-time opt-out or something to give them more flexibility and less reservations when joining up. There's also currently a requirement where single groups can enroll, but the whole group, maybe they've got both represented and non-represented folks have to join. So there's some discussions and efforts around trying to make that so that's not the case. That if they have a group where it makes sense for those folks to come in, we'll let them in. And I'm not necessarily required they bring everybody.
So Todd, can you give an example of that? Because I'm not visualizing that.
Sure. Let me pull up a note here. So when we were chatting with Georgianne about this, the example she had of a couple of groups she's talked to where they had like a union group, but also a non-represented group. Currently, the way it's set up, the only way that group can come in is if everybody comes in at once. So they're looking for more flexibility so that maybe it makes sense for the union folks to come in, or maybe it only makes sense for the non-represented to come in. That it makes sense to let them break that up if it makes sense for a portion of their population. Does that make sense?
Yes, I think it does.
Okay. There was some discrepancies among how dental incentives were handled between plans, depending on the carrier being used and whatnot. There's an effort going on to address that as well. And then lastly, I think I already mentioned this. So while the police and firefighters can come into OEB, currently the plans aren't as rich as what most of them have currently, and that's acting as sort of a barrier to entry. Does anyone have questions or comments on this one before we move on?
One thing that I found in talking with entities that are interested is the plan cycle difference is a barrier as well.
Okay. And when you, just to make sure, I think this is what you mean, plan cycle, plan year, we're talking about the same thing, right? Okay.
Yeah, because our plan starts in October and most plans start in January. And that few month differential is a tough thing to get around for a lot of them.
Okay, that makes sense. We can add this to make sure that it's a point of discussion going forward. Okay, I think we can move on to the next slide, which is probably a 2-slide jump again. So in our discussions internally and with Georgianne, we've been talking about how to market this more effectively and really promoting the value of these groups and joining OEB. And what we really boiled it down to is 5 kind of points of the value proposition. The first being transparency, the voice that it would give them, the affordability piece, political influence and innovation, and then the positive change for smaller groups that may not be able to make the same sort of offerings, et cetera, on their own. So let's talk a little bit more. So transparency around that decision making. and the rates and the benefits that they have access to through OEB. That we feel that's a point that we should make really clear. So folks don't feel like when they join OEB, they're entering into this black box. They actually have more visibility. The voice piece is really just about their ability to make a difference, being able to bring their feedback and input to the board and coverage ideas, and that feedback will be used to shape future strategy for the board going forward. Affordability, this is a big one. As we've already chatted about a few times, the purchasing power involved in a group like this. Not to mention they're experience rated. And then both the 3.4% cost cap as well as the hospital payment cap that these plans operate under. Political influence and innovation, just the opportunity to be a part of this board and help shape what healthcare looks like in Oregon and be able to make an impact on those politics and be able to take advantage of the latest innovations in healthcare.
Do you think there should be a municipal governance seat on the board?
There actually is. JJ.
Is that what JJ has?
Yeah, and then it's one vacant. And Glenn's on. Glenn, isn't there a certain threshold of new additional members that kicks another board chair? Go ahead.
I don't know what the exact threshold is, but it's I think it runs at around 500 or 5,000. So every time you reach a certain number threshold, we have to add more board members who are in local government, both management and also from labor.
Thank you.
Okay. We can skip to the next slide, which may be 2 again. Okay, so what it really boils down to is wanting to get buy-in from you all, the board, on this value proposition, and that you think it's the right one, and that we can focus on marketing this to possible OEB members using a board-approved invitation letter. So again, focusing on that value prop we talked about, it's 5 points: transparency, voice, affordability, political influence and innovation, and positive change. Not sure so we want to open it up to more questions. Also not sure if the board's ready to take a vote on that approach today and move forward, or if it's something that needs to simmer a little bit, but I'm wanting to take your direction there.
Well, I think if we were going to vote, it would have to be a more specific thing to vote on. So I'm not sure if we're there yet.
Okay.
Ollie,
Yeah,
what do you think?
I think just an endorsement that, the board supports staff moving forward in trying to entice, more local government special districts to participate. And, we think we have a lot to offer. The hospital cap is a huge one that Heaven OEB have, and as well as the 3.4% cap. And we're getting a lot of interest from really large local governments, and we just want to make sure that we're operating at the board's vision for OEB.
So what specifically, if somebody were to make a motion, what would the motion look like then?
I think just that. I think the board supports staff moving forward with a marketing campaign and consideration of potential rule changes.
Okay. I don't know who was first, so I'm just going to go JJ because he's closer on the screen.
Thank you. Yeah, I'm in support of moving forward with this. I don't know that it actually needs a board vote, but I am interested in how it is marketed. This is pretty general what you have on the screen here. So what does marketing look like? I think needs substantive fleshing out, but the idea that marketing to a demographic that doesn't have a lot in it, I think, is valuable.
Thanks. Bill.
I'm just a bit confused on this one because I was thinking, and I fully admit that earlier in the day, this very day, I admitted that I don't know much about PEB. But why does this demographic not align, other than the police and fire is not allowed in PEB? Why does this demographic not better align with the PEB plans? Because when we talk about OEB and PEB, the primary difference is the difference between demographics. And this demographic seems to align more with PEB to me.
Really kind of all over the place, what you see out there. I mean, there are some rich plans out there. You know, they may have low risk and a healthy group. There is also, you know, some that would be better off in PEB than OEB, but I think the majority are more interested in OEB than PEB because of the fact that there's a lot more choice, and you know they may have multiple groups, which is similar to OEB. PEB's a Section 125 cafeteria plan, so a little bit different, but OEB's got the lion's share of local governments between the two boards.
It was just a fuel for thought for me.
Yeah, Kirsten, might have a better idea of the kind of landscape out there with smaller groups. I mean, generally, smaller groups can benefit, but they're the ones that are more or less under cities and counties insurance services.
And I would say that's how OEB came together in the first place, because we had the same situation with our smaller school districts, and they were just scattered across the state. And so I see some commonality with city and municipal governments that way.
Exactly right.
The thought-wise, I concur. Demographics is a bit of a stretch, though.
Enrique.
Yeah, so I think it's a good concept to think about. Maybe I just feel uneasy to make a vote today. I feel I need to have more education on the short and long-term impacts of having this. For me, is how is the mission and the vision of OEB benefits this in groups, and how is that going to help the people who are in the system lower the cost of healthcare. I don't know much about PEB, to be honest. I'm with Bill. I think in my mind, if I had, I guess I'd really like that you put political influence and innovation there as your marketing piece. In a perfect world, I think we should be all aiming to provide access to everybody, low cost, and maybe merging PEB or OEB. I'm sure that's not something that most people want to hear or however talk about openly, but I don't know what having two systems is benefiting the community when we see the rise of cost on insurance and healthcare and all that stuff. So just for thought, I just need more education to be able to make a solid vote. I'm not saying against it.
Yeah, I really appreciate those comments. And I think we don't really need a vote today. I think, the main reason for getting this in front of the board is it's been a long time since the board has really kind of been exposed to what we're doing around local governments and special districts. And again, now that we have a resource, to get out there and actually market and do the kind of broker work that we need. This is just reporting back what she's finding, and there's a lot of interest. I really expect there to be a lot of interest in the next year when, a potential bounce back comes and plans are looking at, double-digit increases all over the place. So we just want to be prepared for that.
Yeah, JJ, I'll get to you in just a second. I think Enrique's point on it would be nice to know, at least in a little bit more detail what the benefit to the existing OEB subscribers is.
Yeah.
Okay. And if we're going to be more detailed, then I think what's the plan around the different plan years, because that the current plan year is necessary for the educators, and so I just don't know how that overlaps. JJ.
Yeah, as relates to a vote, I don't think a vote on, hey, let's market. We're already doing that. So it's kind of silly to vote to do the thing we're already doing. But what I would like to see in the future that would require a board vote are some potential rule changes that would deal with how local government entities can come and go. Is there some rules that we can put in place to give them a one-time opt-out, or is there some rules we can put in place that addresses the gap in coverage between when their plan would end or when ours would start? Those are things that would be helpful in marketing, but that would require, board action, and we'd have to look at the pros and cons of those rules. The other thing that I think would be really valuable in our marketing is not just marketing printed / email materials, but also some like short video things. This is what OEB is, this is why you would want to join, here's the advantages, etc. I think that's a good way to market what we have.
Good ideas, thank you.
Anyone else? Not seeing any other hands raised.
Because we're the nicest people in Oregon insurance.
All right, Todd, anything else?
I don't think so. Thanks. There are a lot of good comments at the end. I wrote down kind of a lot of next steps that we can chat about, and we'll be back to you the next time with an update.
Okay, great. That sounds really good. All right.
Thank you.
We're right on time. It's 2:25, actually 2:23. We will still come back at 2:35, so I'll see you in 12 minutes. Okay, we'll get started in a minute. All right, let's get started. I think, Kirsten, you are up next with discussion on trends.
Hi, Damien. Yes, thank you. This is so perfect. I'm going to try to actually do a lot of this on the fly and tie together lots of amazing things we heard from Mary and Bill, and then that also got brought up in the last discussion. I was a little bit wishing we'd had this presentation first, but it's all going to go together and we can all make the connections together today. So just going into really the school year and all of our work together, we wanted to set the stage with basically some healthcare insurance education, just understanding that we all have different backgrounds and not all of you get to be health insurance actuaries every day. So we wanted to start with a topic on trend because really, I feel like I want to say everything. It's a little bit dangerous to say everything, but I'll do it anyway. Everything we talk about at OEBB here in these meetings and innovation work group and CIAO and our work together comes back to some element of trend. And that was really hitting home for me today when I was listening to everybody talk. So the goal of this is not a full comprehensive textbook on trend. It really is the cliff notes to get you thinking about trend and at a deeper level than maybe we are going into the school year. And then really also bring awareness to the kinds of questions that we should be asking and thinking about as we go forward and talk about healthcare transparency and the transparency data and what to do with it. This is going to come up at renewal. It comes up with all of our conversations around point solutions, et cetera, et cetera. For all of our meetings, we'll be able to tie back and have the vocabulary and the concepts to talk about things in more detail. So Rose, if you go through the next slide, actually the next couple slides, because I hit on why are we talking about trend already. So the structure of this presentation, I'll tell you ahead of time. So I have a couple questions and we're going to walk through those. And you are not supposed to already know the answer, although bonus points if you do. You can just have those in the back of your mind. These are the kinds of questions that you'll be able to answer in more detail once you have the trend knowledge. So we'll go through the questions. You can have them in the back of your mind. And then we'll actually talk about the trend concepts. And then we'll circle back to these questions and talk about the answers at the end. And while we go through these initial slides, I can just make sure that we understand a couple concepts too that we'll touch on later. So the first question, so right now with the current level of knowledge that you have, can you think of at least two major drivers of healthcare cost trend? And I'm using cost globally. So when we think about how much OEBB paid per employee per month 1 year versus the next year, what are two or more major drivers of healthcare trend? All right, Rose, next slide, please. Of those trend drivers, of the universe of major cost trend drivers, which were impacted by Senate Bill 1067? And just for a refresher, we use the shorthand Senate Bill 1067. What we're talking about is the cap on hospital payments of 200% for in-network hospitals, 185% for in-network hospitals. It didn't apply to everybody, but it applied to a lot of facilities and definitely made a difference. So that's what we meant by Senate Bill 1067. Next slide. We'll be able to understand which trend drivers, definitely emphasis on plural here, were impacted by, and I guess still are to some extent, COVID-19. Rose, next question. Which drivers are being impacted by the current economic climate? Just to make sure we're on the same page about that. This is what you feel when you go to the grocery store or the gas station and you're like, how is my car taking $90 now for a full tank of gas? And next question. Which drivers are impacted by alternate payment arrangements? And again, just to flesh that out a little bit, we have fee for service is one way of paying providers, where we reimburse you the cost of the service for every service. And the revenue driver there is volume. And there has been an increasing focus on quality and alternate methods of paying providers that focus on driving quality as the outcome instead of just more services. So that's what we mean by alternate payment arrangements. All right. So next, so we can dive right in. Oh, one more. Which drivers are impacted by addressing health equity disparities? So we'll be able to come back and talk about the answers to all of these at the end. So Rose, if you can skip ahead to the slide that just shows, thank you, and one more. Great, so I put the word some in parentheses because healthcare, I feel like healthcare is really too complicated to summarize in some bullet points like this on a slide. But these are, when I think about the most major trend drivers, this is what I'll come up with: unit cost, utilization, mix of services, severity, demographics, and enrollment, plan design, point solutions, outcomes and quality, which we'll kind of lump together in one bucket called other. This is not supposed to be exhaustive. I'm sure people at MODA and Kaiser and maybe some even OEBB board members are thinking about other things not on this list. These are just some to get us started, and then we'll have the opportunity to expand this list and also do a deeper dive throughout the year as other topics come up. So we'll start with unit cost. And these slides are all going to be structured the same. So, and I'm not going to go through the whole slide. I'll just touch on some highlights for you. So some major important points about the concept of unit cost, and then we'll have some examples. I'm going to try to use examples that came up today as opposed to what I have on the slide. And then also thinking about, kind of sticking with today's theme, thinking about during COVID versus after COVID, maybe with an emphasis on after COVID, just because we're sitting now in the fall of 2022. So the important aspect of unit cost for us to all understand is when we really want to measure the unit cost increase of something, we have to be very careful about how we measure it to make sure that we are truly measuring the same thing from time period to time period. And I was just in the grocery store the other day with my son, and he'd never tried Doritos before. And so I picked up a bag of Doritos and it felt like I was picking up air. So not only was it more expensive, but I knew that there was less in that. So measuring the cost of that bag of Doritos compared to last year would not give me the unit cost increase because the weight of the bag had changed as well. And that's what I mean by making sure that we're measuring the exact same thing over time. And how that comes up and why it's so tricky in a healthcare setting is because reimbursement is so complicated. And if we want to measure the unit cost trend of office visits, we have to think about all the different ways that office visits are paid. So we have to think about, hey, if I just grab office visit data for OEBB, I'm grabbing primary care data, I'm grabbing specialist data, I'm grabbing in-office versus virtual behavioral health, I'm grabbing new patient and established patient, I could be grabbing a low intensity visit versus a high intensity visit. So there are so many different, we call them modifiers, but so many different types of office visits that if we really wanted to understand the unit cost increase, we would have to say, okay, I want cardiology visits for, the highest complexity new patient that were provided in an office setting over time, and look at just that one piece. And I mention this now because as we have further conversations about price transparency data, or even analyzing any publicly available data set, we have to understand what's in that data set. Is it a mix of all of these different things? And if so, I'm not going to be able to measure the unit cost of something. Just in terms of unit cost trends, here are a couple things to keep in mind. During COVID, yes, there were unit cost increases. There was some payment mandates that went into effect that influenced how providers were reimbursed for virtual care versus in-person care. The cost of PPE for suppliers, for providers really increased. And then you heard lots of discussion today about upward pressure on unit costs, both from inflation impacting provider costs, drug costs, supply costs, even back office costs such as business insurance costs. And then we have the idea of contracts, and we have to keep in mind we have multiple carriers, Kaiser and Moda, and they're operationally structured differently. So this is a general comment. And then again, I think as we move through the year, we can delve into this and understand the differences between the carriers more. But to the extent that a service is subject to a contract, and some contracts pay a discount off of billed charges, some contracts are a set fee and they're already capped. Contracts can offer some protection against unit cost. And then if we go to the next slide, we'll also be weaving into this discussion today how OEB provides value to its members, both its current members and also its potential members. And Enrique, I definitely made a note about your question, which was sort of the opposite direction, right? Which is, okay, we understand how OEB provides value to entities that are not already in OEB, but what did those entities joining OEB offer OEB? It's kind of the other half of the equation. And this slide is focusing on OEB's value, specifically in controlling unit costs. Senate Bill 1067 was a huge achievement and worked on hospital unit costs for some facilities. There are other things about OEB too that offer some protections. Because of OEB's size and negotiating power and influence, carriers are under pressure to partner with OEB in achieving low unit cost increases, and we have some trend guarantees in place to help do that. The combined size of OEB and PEB leads to additional purchasing power and lower rates for other services. And then OEB's focus on innovation drives things like payment reform, alternative payment arrangements, centers of excellence, and also the reference-based pricing are some examples, and those operate on unit cost trend as well. All right, so next up is utilization, which is maybe in my mind the second biggest piece of trend. And we'll have the same structure, so concept slide, value slide. A couple highlights from today. So for utilization, hospital utilization is up. Emergency department utilization continues to be down. There was a big increase in behavioral health utilization post-COVID that has stayed high. Utilization for virtual services other than behavioral health has declined some as members are showing an interest, and providers as well, in returning back to in-person care. So all examples of utilization here. After COVID, we'll see what happens. There's a really important piece that kept coming up today, which is, you have demand for utilization coming from within the group, right? Like members want to have care, they want to go in for preventive visits, or they want to get their joint replacement. Maybe they have additional mental health concerns. They want to have mental health treatment, and that's influencing utilization. But we also have this idea that supply constraints can be constraining utilization and maybe suppressing it a little bit if there's already full hospital capacity or no additional place for people to go or a provider shortage. And then the other point I wanted to highlight about utilization is that we talk a lot about decreasing utilization of certain services. There is a basket of services where the focus is on increasing utilization. So I just don't want to miss that point. We could call it strategic utilization optimization or something like that. But there are areas, health equity is a great example. If we see a disparity in utilization of some services for a population, we would want to increase it. We're always focused on primary care, preventive care, cancer screenings. Those are all areas where we would want to increase utilization, not decrease it. So on the next slide, again, we'll touch on OEB's value, and I'll stop repeating myself about some of these because they're going to keep coming up over and over again. But some of OEB's big achievements and utilization, we have the additional cost tier. We've talked about that a couple times actually so far this year, and that was an additional copay on certain services that were maybe less medically necessary than others, although we're revisiting that idea now. And the idea was to put some financial incentive in place for members to really consider the need to have that service and ultimately reduce utilization of unnecessary medical services. Also, care management navigation programs play a big role in utilization, both in decreasing unnecessary utilization, but also in increasing desirable utilization. Coordinated care and payment models also impact utilization. All right, next up, Rose, please. Mix of services. Bill Dwyer gave 2 excellent examples of mix of service today. So mix of service, again, says, you know what, in our American healthcare system, there are multiple ways of providing treatment. You can provide treatment in office or virtual, and the mix of those, the ratio of those can change over time. We can also have new services get offered that we haven't before through innovation and technology. And also maybe some old services lose popularity. So the example was that Bill Dwyer gave was about lab costs and how the overall, if you just looked at lab costs in general, it would look like lab costs were increasing. But actually what's happening is that the mix of COVID tests versus non-COVID tests is changed. And COVID tests made up a bigger portion of the lab. You know, it used to be 0 mix, but then now COVID tests are a big portion of the lab bucket, and COVID tests are more expensive than the tests that were in that bucket before. And it's not necessarily a unit cost question. We don't know yet at this point, but because the mix of COVID tests and non-COVID tests is changing, that impacts costs. The other example was the opposite situation where the brand drug trend could look like it was decreasing because there's a mix change and the mix is favoring a lower cost item in that category. Another item that comes to mind in this category, a big mix change with behavioral health, now encompassing a larger portion of visits, and within behavioral health, telehealth versus in-person. And then with technology, of course, and COVID treatment and COVID vaccines and testing, those were all new entrants. In terms of, Rose, next slide, please. In terms of OEB's value, we don't manage, I would say we manage mix of services in that we look to see, are the trends going the way that we want them to? For example, there was a big initiative a while back to say, hey, maybe, you know, all services don't have to be provided inpatient. We can initiate a swing from inpatient surgery to outpatient, and then maybe it was outpatient to ambulatory surgical center. Kaiser talked about their hospital at home program, which again is encouraging a further shift in where certain services are taking place. So we can, by deciding what's the best outcome, what's the best use of, you know, the best value for our dollar, we can develop strategies to optimize the mix of service and drive that ourselves. Rose, next slide. And I know we're kind of running low on time here, and I wanted to get to at least 1 or 2 of our questions. So I'll go through the next couple slides quickly. Severity, an example of this is COVID. And COVID, monkeypox, and long COVID. We talk about with severity, the underlying health of your population, also the intensity or acuity of the services being provided. And Rose, next slide, please. We have the CIAO committee and the innovation work group, which are both working all the time to understand what is happening with the health of OEB's members. Do we need wellness initiatives, point solutions? Do we need to innovate, bring in external partners? Okay, Rose, next slide. Demographics and enrollment. Things to remember here, age and gender and geography impact costs. I think in the interest of time, we'll leave it there. And if you go 2 ahead, Rose. Plan design is another important one. We'll get the opportunity to deep dive into this big time during the renewal. But the cost share network, what providers are in your network, all of the features about your plan design also influence member behavior, where they go for care, how much care they get, how healthy they are, which ultimately impacts your trend. And OEBB does a ton of work in this space. It has huge assets in the CAP committee and the innovation work group and in decisions made in the board committees as well. And then there's one more category for cost trend. There were a couple other things in there, or just an overall trend. Programs make a difference, point solutions that you have. Rose, you can go ahead 2 slides, please. Programs and point solution initiatives. How successful are your programs? How committed are they? How well are they working? What outcomes are they driving? All of the other catch-all trend factors here. So I see it's 2:55. I think of those questions that I had asked, maybe we will think about health equity and skip ahead to the health equity question and talk about which of the trend drivers is health equity designed to impact. And then I'll let you think about the other ones on your drive home from work today, or drive to the grocery store if you're at home. So I gave you a list of things to choose from. We got to talk about a couple of them in depth. We glossed over a few. Unit cost, utilization, mix of services, severity, demographics, enrollment, programs, and other. So if we think about the goal of health equity initiatives and enhancing our provider directory, focusing on providing culturally competent care, connecting members with providers that they relate to, all of the value pillars that health equity embraces. I think about primarily impacting utilization in a positive way, right? I want members to go in and get services that they're not already getting. We hope that impacts severity down the road in a positive way. When you get preventive care now, you have lower acuity diseases later. We also hope that impacts cost, and then, of course, outcomes and overall population health. All right, so thank you for bearing with me for that. It was fast. We'll have the opportunity to revisit these ideas, as we go on throughout the year. But any questions?
Are there any questions? So, Kirsten, I have a question. This was a very informative presentation. So how is this going to link up in the future? I know that on plan design, I understand that piece. So what's in store for the future?
Yeah, so I feel like once you have this information, so for example, here's a live example of how to use this information. Cindy and Prachi from Mercer and others are going to give an update on the Center of Excellence program, which is designed to identify top surgeons for joint surgeries and top facilities. And by top, we mean they're providing the best ratio of outcome for dollar value, and developing a preferred network for members to go to. So you can be thinking about in your mind, okay, these features of the Centers of Excellence program, what trend levers that I just learned about is this Centers of Excellence program going to be impacting? And that's what I meant when I said I feel like this is going to come up in maybe every discussion that we have. So you'll be able to think about these things now in a slightly deeper level. And then, of course, at a really practical level for the renewal, we'll be talking about what do we want to do to trend? Like, what focuses do we want? Which drivers do we want to tackle this renewal? And what direction do we want them to go? And then we can back into what plan design features do we need to focus on in order to drive that particular member behavior. This will come up in transparency discussions as well, because that is a bunch of data now that we're going to try to analyze that has a mix of all of this, all of these different ideas in it. But let's start with the Centers of Excellence presentation coming up shortly.
Great, thank you. Anyone else? Okay, so Kirsten will be talking about this in the future, and we are moving on to Cindy, and let me get the title right. Centers of Excellence update from the Innovation Work Group. Cindy, you're muted.
Sorry about that. All right, please jump to the next slide. So this was our agenda for today. We wanted to introduce members of the OEBB board and others to the team at Mercer who has taken over this project from Towers Watson. So we want to give you an opportunity to meet our team, and then want to give you a project update on what we've been doing for the last few months since we took over the project and what we see as our next steps. You can go one more slide. Okay, and I'm going to turn it over to Prachi. Let Prachi introduce herself.
Hello, everyone. This is Prachi Nagda. I'm a physician at Mercer and partner out of the New York office. I've spent many years in healthcare, from clinical as well as carrier and with corporate in terms of benefit designs and optimizing the benefits for navigating care, especially towards high value care solutions. I've been a corporate medical director at UPMC, helping their employees get access to better care, and also just helping build a COE program for the UPMC population from ground up. So good meeting you all, and look forward to the discussion.
Thank you, Prachi. Carmen, would you like to introduce yourself?
Hi, Carmen Cook. I'm an associate with Mercer's Total Health Management practice. I joined Mercer last June, and I'm based out of the Atlanta, Georgia office, and I'm acting as one of the project managers for this project. Nice to meet you all.
And Chella?
Hi, my name is Chella Blumenfield, and I've been with Mercer since 2019, and I'm also acting as one of the project managers. I joined as a result of my work on the high value care vertical, especially around high performance networks and COEs.
Thank you. And I'm Cindy Crozier. I'm actually a registered nurse on the Total Health Management team at Mercer. And I work very closely with Prachi and the team on the high value care vertical, but also lead the Centers of Excellence vertical, where I help the clinical team with our kind of articulate our point of view, and also very familiar with the vendor landscape around COEs. So it's very nice to meet everyone. I think we can jump to the next slide. Actually, two probably, I think. Slide, yep, just the next slide, I think. There we go. So we just, back one, sorry about that. I just wanted to give the team an update on kind of where we've been since we took over the project in April. Can we back up? There we go, great. So the Willis Towers Watson transitioned this project to us in working with the Innovation Work Group. And we were focused on developing that custom MSK Center of Excellence program. When we took over, the decision had already been made to initially focus on hip and knee joint replacements. And the target implementation date was going to be for the next plan year, starting in October of 2023. The goals of the program are very much focused on quality, so getting members to high quality providers, focusing on avoiding surgery where appropriate, where more conservative care would be as effective. And then for those folks who do need surgery, to make sure that they are seeing very high quality physicians in high quality facilities to reduce complications and readmissions, and hopefully get folks back to their everyday life more quickly. We have been working very collaboratively with MODA, Providence Health Plan, and Kaiser over the last couple of months, looking at the Oregon facilities and providers, working to build consensus around how we identify top performers. And we're looking at both quantitative data, so things like volumes of surgeries, complication rates, surgical infections, readmissions, length of stay, so those types of metrics, but then also looking at qualitative data as well. So board certification, quality oversight, patient safety committee, these kinds of things, policies around BMI and tobacco use in terms of who are good candidates for surgery, those types of things. So it's been a very comprehensive look at the providers. Any question on that background before we move on to kind of where we're at today? Okay, great. Now I think if we could move ahead. Yep, one more slide. So we wanted to kind of outline the approach that we've taken in sort of assessing the market. What we did initially was identified key markets or regions within the state of Oregon where the majority of OEB members lived or sought care. And then based on those markets and regions, we looked at multiple data sources to identify quality. And we're still in the process of continuing to do that. So we haven't got it all defined at this point yet, but we are making significant progress. So we're looking at quality within the whole state of Oregon, but then also within these key markets and regions. Some of the data that we're using, Mercer we partner with Clarify, which is a data warehouse, to on a proprietary quality tool called QualPick. It's focused on those episodes of care for knee and hip replacements. So we're looking at facilities at that episode level. We can look at both facilities and providers. The data is representative of Oregon residents statewide. So this isn't just OEB members or PEB members. It's all Oregon residents. And the database is estimated to contain about 100% of claims for about 20% of Oregon residents. And it includes Medicare, Medicaid, but also commercial. The commercial database is about 2 times the size of the Medicare or Medicaid databases. So it's primarily commercial data. Other data that we're looking at are carrier reported metrics and experience based on their book of business. So asking them to provide us with similar metrics around volume and complication rates and those types of things based on their actual claims data for their book of business. And then facility and provider responses to a request for information. So we've already received facility responses to an RFI for 2019-2020. And then we have a provider RFI that we're going to be launching shortly. And then what we do is we are working with the IWG to identify strategy recommendations for the OEB board. Things like, the number of facilities and providers that are going to be needed to support OEB members, because we want to avoid things like access issues or capacity issues. We want to make sure folks are getting to high quality providers, but also that they're able to get in to see them and have surgery if they need it, in a streamlined way. Developing network strategy recommendations. So, do we think that it's a good idea to have a very narrow network or a more broad network? So we're working through some of that. Plan design incentives or disincentives that would be needed in order to have the MSK COE program be successful. So, benefits for members if they use one of the COE providers compared to a provider who maybe isn't in the COE network. And then also travel benefits as well, if folks are going to need to travel to access one of those high quality providers. And then we're also doing some actuarial modeling to identify the potential impacts to both outcomes and costs. So reductions in readmissions, reductions in emergency room visits or complications or infections, those types of things, and how is that going to impact both outcomes for members, but also costs based on those quality improvements. Any questions on that? Okay, great. If we want to go to the next slide. So this is just kind of a visual of that same process. So we define the regions within the state of Oregon. So we called them Metro, Central, Willamette, Southern, and Northeast. We determined the care category, which was MSK, narrowed down even more so that we were looking at knee and hip replacements. Looking at the contracting entity level, which is the facility level detail, so facility quality and volume, and then also looking at providers associated with those facilities, looking at things like infection rates, complications, readmissions, and then that qualitative data that we were discussing. So those last two are the two where we're still focused. We are looking at data for 2019, 2020, and 2021 to give us a nice time horizon. To we don't want to make any decisions based on a single year of data. We want to make sure that we've got cumulative data that we can feel confident is correct. We can go to the next slide. So this, we just wanted to share with you all the regions that were defined, and we worked with the IWG and also our actuarial partners to sort of define these regions based again on where majority of OEB members either live or seek care. We wanted to make sure that we were able to minimize travel as much as possible by identifying top providers in each of these regions so that we'd have the broadest access across the state. Okay, we can go to the next slide. So we've been working on the facility evaluation to date. MODA and Providence had issued an RFI, as I mentioned previously, in late 2021, and we have completed an initial review of those criteria. These criteria we really felt like were sort of minimum quality criteria. So looking at total volume, accreditation of the facilities, patient safety committee, the fact that they track and report outcome measures, especially related to orthopedic care, that they have documented protocols around physical therapy and pre and post-operative functional assessments, that they do promote conservative therapies prior to surgery. So again, looking at that appropriateness piece, and then also looked at complication rates as reported by the facilities. We can go to the next slide. We wanted to give an example of the data that comes out of our QualPick tool. This was our kind of level 2 evaluation for facilities. This chart represents the top 10 facilities by volume, and that's knee and hip replacement volume for 2020. From the Clarify database, the results here are an actual versus an expected. So these readmissions, length of stay, and efficiency are the metrics, and they are risk adjusted based on the severity of member condition and that type of thing within the database. So looking at the risk adjusted expectation, and then did the provider perform better or above that, above what was expected? So that 0% actually represents the expected, and then the results below the 0% are those metrics that actually were better than expected. So you can look across here and see that provider or facility 1 and facility 2 and facility 3 look really good. They've got all of their metrics kind of below the 0%. Facility 1 definitely had the best kind of overall performance. Then you can kind of look across and see that some of them were above what was expected, especially on readmissions, a couple of them, and then length of stay. Provider 7 had a longer length of stay. We have these, we're actually looking at the data on a facility specific basis, the same kind of data. And then we'll be looking at it across the whole state as well as within each region. And again, we're going to do a 3-year analysis of that, 2019, 2020, and 2021. And I'll pause here because I know this might take a minute to kind of orient yourself to this chart, but are there any questions about this? Okay, great. Okay, so we can jump to the next slide. This is where we are right now in terms of provider and surgeon evaluation. This is in progress. Again, we're pulling 3 years from the QualPIC database, and you can see there in the green box the metrics that we're utilizing: surgical site infection complication rates, readmissions, ER visits, post-surgery, admissions so admissions versus ambulatory care, the volume of procedures, and then efficiency, which is actually resource utilization. So it isn't a dollar specific figure, but it's an expected use of resources based on the risk level of the members. And did the provider utilize more resources than were expected or less resources than were expected? So those are the QualPIC metrics. We also are working with MODA and Providence Health on these carrier reported metrics. So we'll have these in addition. You can see volume of procedures, revisions, physical therapy. So some things that aren't easy to see in the QualPIC database, but that the carriers are able to pull, looking at our members being optimized with physical therapy, both pre and post-operatively, looking at opioid use, the volume of patients with a comorbid chronic condition as a proxy for understanding the severity of the members for each provider, post-op complication rates, emergency room visits, and readmission. And then the last piece of our provider data is going to be this surgeon reported data. So we have an RFI that we're teeing up to send out to all of the providers, all of the surgeons. And this is trying to get it more qualitative data. So their board certification, practice guidelines related to BMI, surgical patients who met the BMI guidelines, tobacco use, satisfaction surveys. So looking at provider satisfaction from members. Now, all this data will be combined in order to come up with our consensus around the best approach to identify sort of the top providers within each region. I'm going to pause. Prachi, anything you'd like to add on any of the evaluation criteria?
No, I just wanted to thank also the carrier partners for their partnership in, being patient with us and waiting through this process and actively participating. So.
Yeah, they've been extremely helpful in sort of navigating the process for sure. So we appreciate that. Any other questions or anything on this provider or surgeon data? I'm leaving you all speechless. Okay, please, if you want to go ahead to the next. And then the next steps. So, kind of our next steps, still looking at physician quality. We want to summarize the list of high quality, efficient surgeons by region, develop in collaboration with the carriers, the standard policy guidelines, and defining kind of what would be included in bundles for the MSK COE procedures. Continue to analyze the financial data to develop plan design recommendations and what we believe the potential impact may be for, pulling some of those different levers around incentives and how broad or narrow the network may be. The incentive structure, we'll be talking about that. And then working with the carriers, once we've identified sort of those high performing facilities and providers, to start to begin those contracting discussions, gauge interest, make sure that we're thinking about how to structure those contracts to be most favorable to OEB and your members. And then ultimately working with the IWG, review those recommendations with the OEB board. If you want to jump to the
Cindy.
Yep. Go ahead.
I was going to ask a question. Can you give just a broad example of what an incentive structure would look like to entice providers to do this?
To entice providers
what does that look
or
like?
members?
I think providers is what I'm shooting for. Yeah.
Yeah. So for this particular effort, it's mostly will be focused on volume, right? So funneling the majority of OEB members to, a narrower network of high-performing providers, and so that would be the incentive. Prachi, I don't know if there's anything additional.
Yeah.
Okay, just
I think, go ahead. Sorry.
I'm sorry. Go ahead. No, please go ahead.
I was just going to say, to what Cindy mentioned, there'll be increased volume, and also, for the providers, they will be considered, high quality providers as well. So there is that, again, qualitative aspect that providers strive for as well. So definitely that, and as Kirsten and will also be working through from an actuarial perspective. As we work through the numbers, what does it look like and stuff. So, there could be some financials tied to it, but too early to say right now as we work through the modeling and those pieces.
Great, thanks for both answers.
If you want to go to the next slide, we have kind of a timeline. So here in September, today we're updating the OEB board on the status of the project. We'll be working on collecting all of the provider RFI responses, the QualPIC data, and also the carrier reported information, and consolidating all of that, working to define that standard COE policy, and then model some of the plan design options and potential impact. In October, we would be working with the carriers to review all of that data and identify the high-performing facilities and providers. So come to consensus on, sort of who we would include in that high-performing network. Update the IWG, and with all the recommendations, discuss with them, answer any additional questions they may have. In November, kind of begin discussions with facilities and providers regarding their willingness to partner to deliver the services, and work with the IWG on finalizing those recommendations. We're looking to provide the recommendations to the OEB board in December, especially regarding the network and plan design strategy that might be required. And then we would be looking for the OEB board to vote on whether to move forward, probably January or at least early 2023. Any questions?
I'm also interested in how you're going to convince, especially in my case, for as an OSBA member, the rural leadership to really push this politically. There's going to be a difficult sell to our places that are a distance away. It'll also have perception implications. You're just trying to save money. And I'll point out the obvious that one bad COE experience will be louder than 100 good COE experiences. This is something to not just something to say, okay, we can do this and it'll be benefit the member. The member won't see it that way in rural side, unless they're sitting next to the hospital that you selected. Right. This will be a hard sell.
One of the things that we will be focusing on too is the disruption. So looking at where people are accessing care today and, you know, is the network broad enough to make sure that they do have access, you know, that isn't going to be too onerous.
I think the primary question that'll come out is, you know, was there a way to do this that actually doesn't take potential education and improvement at rural facilities by moving business away? Is there a better way to improve the healthcare in the region instead of moving healthcare away from the region?
I think that and I'll say this, and then Prachi, you please jump in. But I think the plan is that there will be a path forward for, you know, all facilities and providers to ultimately, you know, be within the network. So it will be sort of a narrower network at the beginning, but then ultimately we want to make sure there's a path for all of the facilities who maybe didn't make the cut, so to speak, to improve their metrics and ultimately be a part of it.
That'll have to be a big part of the branding of this. I mean, to really convince people that you're not just saving money on their backs.
Yeah, and we are not at this point we aren't even looking at cost as a potential metric. So it's 100% right now focused on quality.
Yeah, and I think, Bill, to that point, absolutely agree. It will take an educational effort, and as Cindy mentioned, the focus has been on quality and ensuring that, you know, again, your constituents and are getting access to the best quality providers locally, and, you know, keeping care local, but also making sure that it's routed to good quality providers. Yep, absolutely.
Did Bonnie have a question?
Yeah, I was just wondering, I'm from that northeastern section, the big blue one that you had, but will there be a possibility of crossing the state line? I'm 30 miles away from major cities, major hospitals. One way or the other is going to be 30 miles. So that's my question. Is it going to entail different areas or just within?
So I can tell you that we are looking at facilities that are outside of the state of Oregon, although the primary focus was on facilities that were in Oregon. But we're looking at the disruption as well as we do have quality metrics for some of those facilities that get a lot of utilization by the OEBB members. So. Any other questions? Well, we look forward to working with your team and with the IWG, and we will be excited to provide some more specific data, hopefully, on our next update. So thank you very much. It was very nice to meet you all, and again, we look forward to working with you.
And thank the three of you as well. Thank you for the presentation. Okay. Okay, we are at right on. Well, we're a little bit early. Ali, you're up with HB 2010 Global Budget Report Update.
Well, thank you, Robert. So you might remember the House Bill 2010 Global Budget Delivery Model Bill. This is from the last legislative session that required the Health Authority to submit to the legislature by July 1st a report outlining recommendations for a regional global budget healthcare delivery model pilot. And I sent the board a link to the report and an executive summary earlier this summer. The pilot incorporates participation of PEB and OEBB, the Health Insurance Exchange, CCOs, and potentially other employer plans, and it is aligned with the state's healthcare transformation goals. It's now in the legislature's hands, the report. We haven't received any questions back related to the report or the global budget concept in general. I do know that Representative Dexter's office, who sponsored the bill, is having a meeting with legislators in September to discuss the findings of the report. So we'll be watching for a bill in the upcoming session and keep the board updated. Let me know if you have any questions, and I'd be happy to resend the report link out if you need it. It's been a little while. And just as a refresher, a global budget means a lot of things, but essentially it's built around a sustainable rate of cost growth, kind of like we have a 3.4% annual growth budget per employee per month. It attempts to change incentives for payers and healthcare providers from the current system, and promotes delivering and paying for individual services that incentivize improving health for the full population in a region. There's obviously health equity considerations, metrics, and many other things that would be featured in such a model. The report actually recommends an RFP, which would be a multi-year endeavor. As you can imagine, would be quite complex, so would take resources and anyway, if you have any questions, feel free to send them my way, and hopefully we'll have some updated information for you soon.
Any questions regarding that particular issue? Seeing none, Ali, how do you want to handle the CL report? I did not take notes.
Yeah, no worries. Glenn Bailey's actually going to deliver it for Tom.
Glenn, okay.
Yeah, thanks, Robert. I'm going to go ahead and give the CL update, probably not as good as Tom did, but most of our meeting was actually spent on reviewing the utilization reports for medical preventive services, telehealth utilization, and also dental preventive services. These have been reports that we've been doing for about the past 6 months frequency. Since pretty much the start of COVID. The purpose of these reports that we have from our carriers is to look at what has been the impact of COVID, and then are we getting back to kind of a normal state. For the medical preventive services, both Kaiser and MOTA reported. We looked at the utilization. Overall, we're finding that the services have pretty much gotten back to pre-COVID levels, but there still is some gap, especially on certain services. We also looked at health equity. We looked at race and ethnicity, age and gender, as well as on a side note, we looked at geography too. There are some gaps between in certain areas on that. And then we also asked our carriers, what are you going to do about areas where we still need to improve? And they provided us their activities that they're currently working on for that. For telehealth, the purpose here was not so much to look at what was the impact of COVID and have we gotten back to, say, pre-levels of face-to-face versus telehealth services, but was to look at this more in a sense to see what has been the change. Has there been some really big changes in regards to the adoption of telehealth? There was a big adoption of telehealth, especially back in 2020, when clinics and doctors' offices were closed down. That is starting to wane a little bit. The face-to-face is starting to come back up, especially in primary care and somewhat in specialty care. However, there has been literally a whole shift almost from behavioral health services going over to telehealth. There's been a big adoption and on that by providers, and our carriers have done a lot of work in offering new services from a telehealth standpoint, especially in the behavioral health ring. For dental, dental has seen, they are not fully back up to for dental preventive, not back up to the levels of pre-COVID. And the carriers kind of discuss what are some of the reasons that could be causing this. One of those was that people are still reticent, maybe about coming in for a cleaning. And the other thing too is staffing, especially hygienists. There's been the pool of hygienists is really kind of shrinking in regards to and the cost for getting hygienists. Overall, like I said, we've been doing this almost every 6 months for on the quarter almost. And it was offered that we would really, move this more to an annual, since we pretty much have gotten back up to the levels, but now we're, seeing that we're pretty much back up to the levels. I wanted to, the second half of the meeting was to discuss our charter, work plan, and also a pilot project that we have started working on in regards to really joint PEB-OEB projects. And excuse me, let me just get down there. The charter is pretty much the same charter we've used before for CIAO. As you know, CIAO is a work group that is made up of OEB board members. It was created to oversee a broad range of issues and topics, from quality to wellness to just in general to service quality. Our roles really at CIAO have been to review and select measures to evaluate data and information like we did today and make recommendations to the board, to review and evaluate and make recommendations, excuse me, to the board on plan design and benefit design. There was really no changes. The only change we had was we added to the roster, we added the Mercer folks there. So this was agreed on by CIAO, and I'm just wondering if any of the board members had any questions, concerns about the charter, and whether you approve of, going forward with this charter for this year.
Are we sharing something that I'm not seeing? The charter, that is?
Is it not coming up on your screens?
It is not.
Oh, sorry.
I think you're on display 2, and you're probably got your charter on display 1.
I apologize.
Good detective work, Bill.
Same issue.
But Glenn, you said the only change to the charter was the change from the Willis Towers Watson consultants to the Mercer consultants on
Yeah.
support. Okay.
Is it now showing?
Yep, you got it.
Sorry about that. Yeah, the only change was moving to the Mercer consultants. Well, if none of the board members had any issues with it, I can go on to the next topic, or
Yeah, I mean, see, I'll be operating as it did last year, so.
yeah, okay, sorry. So
no, I think it's a good reason to pause and see if there's any input. But all right, Glenn, let's keep going then.
okay. The next thing we talked about is with the convergence of the interests of PEB and OEB and the desire to have more collaboration between the two organizations, as was seen with Senate Bill 1067. We're looking at doing, and especially with hiring a single consultant, we're looking at exploring ways to identify additional opportunities to leverage PEB and OEB purchasing power and data, identify opportunities to maximize PEB and OEB resources focused on plan management, plan design, performance reporting, such as CIAO has worked on in the past. And then also just to clarify the boundaries and kind of lines of authority between CIAO and IWG, which tends to work on, as you saw with the Center of Excellence, more kind of high level and really projects. So what was proposed and agreed on by the leadership was that CIAO would work over the next year to conduct a pilot project that addresses select number of topics that affect CIAO and OEB. We looked at about 3 to 4 topics, as possibility, and to make recommendations or report to, dependent upon the topic, to the PEB and OEB boards. We'd invite 1 to 4 PEB board members, dependent upon their, availability to attend. We could certainly have more. And then this was done for several reasons, to make sure we'd have PEB board member involvement, but also to really, since CIAO it operates on kind of a consensus and not on a specific vote, basis. And then we'd also have the PEB Mercer team and PEB staff that would be involved in the planning. CIAO would then report on the experience in addressing these joint issues and provide recommendations on next steps at the end of the year to both boards to see, for them to look at. Again, I just want to, one thing I want to stress is CIAO has been very successful and very important to OEB. This is really kind of looking at, can CIAO fill a role on a limited basis, or at least through this pilot project, to see whether we can help with the kind of convergence of PEB and OEB issues, or looking at areas that affect both of the organizations. We've already kind of started moving forward with that. We look at one issue in October, and that would be looking at performance measures for the clinical quality area. And so again, this is just a pilot project. The idea is to look at how it operates. Did it meet the initial goals, and what was the impact to try and do it? So we wanted to make sure we updated the board on this. I know we had talked to a number of the leadership already and talked to CIAO today, and to see if there were any concerns, any questions, any changes that you might want. Okay. Since we don't have any, let's move on to our last issue, which was we looked at the work plan. And I'm not going to go into each month because we have a limited time. We set year-long work plans for usually September through September of the next year. These are, draft work plans. They, of course, do change over time if we, when we have to move issues or add to issues. As I pointed out, we did the telehealth today. We'll be doing a number of really evaluation quality issues over the next fall. And then we'll look at wellness programs in the winter, how they performed, and then what ones we'd want to do for the next year and make those recommendations to the board. And then most of really January through March will be involved in really evaluating plan design changes or proposals that come through either from carriers, staff, consultants, and then making recommendations to the board. And then in the spring and early summer we'll look at, I'll just go down here, we'll do our annual medical reports and annual dental reports. If board members have any, suggestions, any other issues you'd want to see, or then feel free to, you can send those either to Rose and she can forward it to me. Okay, that's what we worked on today.
Enrique does have his hand up, so.
Oh, I'm sorry.
Yeah, just.
Oh, it's okay. Too. Maybe skimming through fast with the board report, but I don't have that. If you could provide that, it'll be helpful.
Sure.
I can provide some feedback. Thank you.
We can send it out to all board members.
Thank you.
And that was the only comment, Glenn.
Okay. All right. Well, yeah. Well, we'll send out the work plan for folks to comment on, as well as we can send out the charter if you have any comments on that. But again, this is the same charter that we've been operating under.
Okay. Well, thank you, Glenn.
Thank you.
We are now at the our favorite part where I ask Rose, is there any public comment?
No, there's no public comment.
Okay. Well, then I will call this meeting into adjournment at 3:47 p.m. And I will see all of you in October.